We want to thank the CVI Selection Committee for the opportunity to present our case titled Deep Venous Arterialization for No Option Critical Limb Ischemia in COVID-19 Era and the Role of Social Media. Our patient is a 62-year-old male with history of coronary artery disease, COPD, and diabetes. He's already legally blind from diabetes, retinopathy, has already had a right below the knee amputation, and presented with critical limb ischemia and gangrenous ulcers on the dorsum of his left foot. On presentation angiogram, he had an occluded left AT, TP trunk, peroneal, and PT arteries. AT reconstitutes in mid-calf, but the DP is occluded in mid-foot with very poor runoff at the foot level and essentially desert foot. He underwent orbital atherectomy with the anterior tibial artery with a 1.25 mm microcoron, intravascular ultrasound-guided angioplasty of the proximal to mid-AT with a 3 mm chocolate balloon and angioplasty of the TP with a 2.5 mm non-across balloon with this final angiogram result. At 2 weeks, he only had modest improvement in his TCPO2, which was deemed not to be adequate for wound healing, and given the presence of a small vessel disease at foot level due to advanced diabetes, this venous arterialization seemed to be the last resort in order to preserve his limb. We had not performed DVA before, and given travel restrictions due to COVID-19, there was not an opportunity to observe a case or have a proctor for the procedure, so we discussed these limitations and obtained patient's written permission to discuss his case with world experts via social media platforms and mainly Twitter. After receiving input from several experts, the DVA was strategically planned. DVA of the TP trunk or PT artery to the posterior tibial vein was planned. DVA of the AT was not attempted because AT was the only runoff vessel despite the presence of a small vessel disease at the foot level, which we didn't want to compromise. And staying interluminal in the proximal TP trunk and PT was deemed critical to create a functional shunt without compromising the AT. So these are the DVA steps. The antegrade left CFA axis was established. Popliteal angiogram showed significant recoil of the proximal AT, as you can see in the arrowhead here. Contralateral projection identified the proximal knob of the TP trunk, as you can see in the solid arrow. Using a command 014 wire and a 014 CXI support catheter, posterior tibial CTO was crossed, as you can see in the hollow arrow, and interluminal wire position in the proximal 1/3 of the posterior tibial artery was confirmed with intravascular ultrasound. After that, the proximal anterior tibial artery, which had recoil, was stented, and balloon angioplasty of the left TP trunk and the posterior tibial artery was performed with a 3 mm balloon. Left posterior tibial vein axis was established and a 5/6 French slender sheet was placed in the posterior tibial vein. Simultaneous arteriogram and phlebogram was performed in the site of fistula creation, as you can see in the hollow arrow in the proximal posterior tibial was decided. The next step, an 018 wire was placed in the posterior tibial vein, which made posterior tibial vein identification and reentry easier with the Pioneer device. A Pioneer plus reentry device was advanced through the arterial axis, and the artery was punctured into the vein, and a 300 cm Miracle Pros 3 wire was advanced into the vein. The puncture site was more proximal at the TP trunk artery into the TP trunk vein, and the reentry wire advanced into the peroneal vein instead of the posterior tibial vein. A 2-impasse dual-axis catheter was used to direct a command 018 wire into the posterior tibial vein, which was then externalized through the posterior tibial vein axis and provided an excellent rail support for delivery of balloons and stents. Command 018 wire and a command 018 support catheter was used with wire loop technique to cross the valves in the posterior tibial vein and the deep venous arch. The fistula site was dilated with a 3.5 mm NC balloon, and a 3.5 by 26 mm graft master covered stent was used to cover the fistula. The posterior tibial vein was dilated with a 5 mm balloon and then stented with a 5 by 250 mm wire-bound stent with a few millimeters of overlap with the graft master to just above the ankle. There was a distal valve in the posterior tibial vein at the level of the lacinated ligament that would not dilate despite using 3.5 and 4 mm cutting balloons, scoring balloons, and high pressure NC balloons up to 30 atmospheres, And even with the piercing technique, in which external destruction of the valve with several punctures with a 21 gauge needle was attempted, as shown here, this valve was disrupted with nominal inflation of a 4 mm valvular balloon and rubbing the valve against the balloon from the outside. Further angioplasty of the lateral plantar vein was performed through the foot with the 4 mm balloon. A final angiogram, as you can see here, showed excellent result with successful fistula creation. In conclusion, desperation breeds innovation. Despite enormous toll of COVID-19 and loss of human lives, COVID-19 also forced the 2020 healthcare systems to use modern technology and make healthcare more accessible and even more affordable through telehealth and telemedicine. Here we present planning a complex endovascular procedure for the first time by consulting experts via social media. Social media platforms such as Twitter provide a unique opportunity to collaborate worldwide, discuss complex cases, and seek experts' opinions. We encourage our colleagues to be involved in such platforms while respecting patients' privacy rights. And thank you for your attention. Foot Doppler the following day showed Doppler fistula an excellent shunt volume of 241 milliliter per minute at the posterior tibial vein.